Good morning, everyone. Thank you for joining us, Pediatric Grand Rounds today. Please do come and join us in the Mill Mountain Conference Room in the Tanglewood Complex if you're anywhere nearby. As always, thank you for joining us virtually. Today's speaker is Dr. Rebecca King, one of our soon-to-be graduating third-year residents from the Pediatric Residency. Completed her medical school training at VTC SOM. Completed undergraduate at UNC Chapel Hill in studio art and biology. Her interests include lactation medicine, medical education, neurology. During her time here, she served on the PEC committee. Her QI included improving resident conversations with lactating moms, and she will be staying locally. Please join me in welcoming Dr. Rebecca King.
All right, good morning, everyone. I'm going to go ahead and jump into things because, as most of my peers know, I tend to be long-winded and I have a lot that I want to get through. So I'm going to be setting timers for myself and may end up kind of zooming through a few things. All right, so this is a talk about the American residency system and where do we go from here. It is sort of like a follow-up to Dr. Muller's Grand Rounds earlier this year, where he dove into more of the history of medical education and training. Disclosures, I don't have any financial disclosures. I did use ChatGPT in the making of some of the visuals of this presentation. And Kenneth Bledmer's Let Me Heal. This book served as really the primary resource, the inspiration for this presentation. If anyone has an interest in this topic, I do recommend highly reading this. And he said in this book, a central characteristic of an educational system is implicit in its name. It is a system. So our objectives today, we're going to review the evolution of education, training, and patient care in the U.S. I'm going to try not to focus too much on that since Dr. Muller did that earlier, but just as a refresher, because I know that was a little bit ago. Then you go into analyzing factors that influence the learning environment and quality of patient care in residency, as well as discuss current and hopefully have some time to propose future efforts to reform residency. All right, so getting started, just a brief overview of the evolution of medical training. Really started in the apprenticeship system, and these roots are really evident throughout the evolution of graduate medical education. There was eventually a rise of these proprietary medical schools as medical knowledge expanded. This was meant to be more of a supplement to the apprenticeship system. It was not meant to replace that system initially. And typically you had to have three years of apprenticeship experience before you could attend a medical school, which was usually 2 years, consisting of like a winter term each year. Eventually, that 3-year apprenticeship requirement went away, mostly because people were finding ways around that requirement. You could pay somebody to say that you had apprenticed with them. So that faded, but then you were left with medical school, kind of more theoretical education, and so something needed to come in and fill that gap of how do you get your clinical experience. And that's when we started seeing house physician or resident positions, and these were called many different things, but this is not to be confused with what we now call residents. This position was actually more the antecedent to an internship. So around this time is when Halstead and Osler created that first residency program in the U.S. at Johns Hopkins, and that was in 1889. It was initially created to produce clinical scientists who would generate medical knowledge. It was trying to get America more in the leading the medical field, and intended for just a small group of people with exceptional scientific ability. William Osler was quoted as saying, "It's for a superior man who also wishes to do scientific work." And so with that, they created it as a pyramid structure where just because you started a residency did not mean that you would finish a residency. Every year there could be cuts, even if you were doing a great job. And so there ended up being many programs that became extremely and unnecessarily competitive within it. This graphic is just an example of the OBGYN service at New York Hospital in the 1930s, just showing what that typical pyramid of residents looked like over the 5 years, and then ultimately culminating in that chief residency position. Mayo was the exception. They were the first ones to do more of a parallel system or rectangle, where if you started it, there was always a position for you to move on to if you did well. So you may remember Dr. Muller talking about the Flexner report. This was really instrumental in standardizing that undergraduate medical education piece. And those house physician positions I mentioned is really what turned into the internship, which was separate from residency. They were usually 12 months, but could be longer. The straight internships, which were on one service, were at mostly teaching hospitals. The rotating or mixed internships were primarily at community hospitals. And then after you completed your internship, you could go on to be a general practitioner, or you could choose to specialize. So initially, when all of this got set up, there was a lot of question about, okay, this internship mark, undergraduate medical education, that the culmination of that, or is it actually within graduate medical education? And it really wasn't until 1923 that there was enough internships to actually accommodate all medical school graduates. So it wasn't a guarantee after you graduated medical school. And that was the same for residencies, where initially only a quarter to a third of those graduating from an internship had an available long residency slot. And so that long residency slot is what we think of as what it was, the Halstead and Osler pyramid system residency. It was at least 3 years. But there were all these other routes that could lead to specialization at that time. So general practitioners could take short courses at post-grad institutions and self-declare after like 2 or 6 weeks of a short course that they were a specialist in the field. People still studied abroad, or they went to a formal graduate program on a specialty. And then there were some other short residency programs that were done at community hospitals. And so ultimately, when specialties decided, they started forming their boards, and the advisory board for medical specialties formed in 1933. It was an umbrella organization for all the specialty boards, and they basically said that after 1942, only the long residency. That's the only acceptable route. That's the only way that you can become board certified in this specialty, which then led to residency review committees being formed, and ultimately ACGME became the group over top of all the residency review committees. And now this is kind of what we have. So much different, and grown so much in the different specialties and then subspecialties. All right, so moving on to kind of that initial learning environment. when residency was created. There was a diverse and abundant patient population, and this was especially true in larger hospitals, urban areas, and the diseases that they saw tended not to reflect prevalence in the general population, but that was thought to be a good thing, and seen as enhancing the learning environment. Most of the patients were charity, or what they called ward patients, and so they could not afford to pay for care. They were receiving their care kind of as you receive care for free, we get to learn on you. You are clinical kind of material. The faculty within residencies really had a deep commitment for teaching. That was really their passion. And there was sufficient time for house officers to do their jobs well. So much so that teaching hospitals would hire far more officers than they needed, or far more than non-teaching hospitals to do the same amount of work for patients. And so what happened in kind of the years between when residency was initially created and where we are now? We've had a lot of advances in medical knowledge, technology, therapies. And so with this, we had the average length of stay, which in the late 1800s could be up to 80 days, now down to closer to a 5-day length of stay. So it's really decreased the amount of time that you're with the patient. And these graphics are not meant to represent any sort of actual rate of rise. This is really just meant to depict the increasing in admissions. So during this time, we also had, increase in the number of admissions, the complexity of the patients presenting increased, the acuity, and life-altering decision-making. And so there were, when I was reading about the history of what life was like for some of the residents early on, before we had so many advances and before we knew enough to do things about life-threatening situations, they would live in the hospital, but they would say, in life-threatening situations, patients typically lived or died on their own. The residents weren't present at bedside. There was not much for them to do. So it wasn't like running to codes and actually trying to save them. They either lived or they died, and that was not really on the resident to take care of. And so with this, as we saw earlier, the advances led to further specialization and subspecialty fellows. And so then you have fellows added into the mix for learning and competing sometimes with residents for patients and responsibilities. And like residency, fellowships were initially created with that idea that there would be a few really academically inspired folks who would go into it to try and further that subspecialty. It really wasn't initially meant to be for everyone who wanted to practice that specialty. And so we saw a decline start happening in exam skills. Some of this has been attributed to the rise of CT scans and other imaging technology. What once you needed to have really great percussion skills or really be able to determine the size of the liver or the spleen now became, well, hey, I can just get them a CT and I can see what's going on inside the body, right? I don't need to actually know how to do this. There also became excessive use of tests and procedures as new things came about, which ultimately leads to this problem of increasing cost of care. These tables are a little bit small, but really they're just shown to give you an idea of, on the left, you've got routine diagnostic tests from 63 to 67 at Presbyterian Hospital. And all of them are increasing over time. You're just seeing a rise in the ordering and the use of these tests over time amongst everything. And whenever something new comes out, like EEG, for example, it starts off in 63, you've got 6,300 tests, and then in 4 years, you've already increased to 7,700 of these procedures being performed. And then we're still doing charity care at this point, is what they call it, operating on the wards. And so as costs are rising, there's a problem with how do we pay for it? And you can see from Mass Gen Hospital's income deficit and free care table that by the time we got to 1964, right before Medicaid and Medicare were enacted, they were losing a little over $4 million on free care. So during that time, there was this expansion of the medical and residency systems where there was more demand for medical care, more hospitals being built. Patients had the ability to pay and to have insurance. And so there was a decline in the ward service and the amount of people who were on teaching in what they call teaching beds. And then there was more desire for specialization. Instead of finishing your internship and becoming a general practitioner, now everybody wanted a residency. Everybody wanted to specialize. And so general practitioners ended up becoming family medicine as a residency. So you had these increase in residency positions. You can see like a tremendous growth in that 30-year period. There were 5,800 approximately positions in 1940, and that grew to 46,000 residency positions by 1970. About 80% of this growth occurred at community hospitals that were not affiliated with medical schools. And then also the pyramid system eventually gave way to the parallel system. All residencies became rectangles where if you started it, there was an opportunity for you to complete it. But this is also where a lot of talk started about this idea of service over education and whether the residents were more for serving the hospital and not service in terms of service to patients, but service to the hospital or the hospital system and to their bottom line versus what educational benefit they received from the hospitals. And there became a dependence on house staff where many hospitals, they use house staff for both clinical and non-clinical needs to keep costs down, and got to a point where it was difficult to function financially without them. But the cost of care continued to skyrocket. And so one of the big things that I think in my reading affected probably the learning environment the most is this shift in hospital payment. So in the 80s, when the third-party payer said, we're bearing all the financial risk, y'all are basically doing whatever you want in these hospital stays, and then we're retroactively reimbursing you, trusting that this was all necessary and needed. And so they ended up going towards a prospective diagnosis-related group payment. So regardless of the actual cost of the hospitalization, they were going to pay this amount for this diagnosis-related group. And now hospitals could try and control costs and make a profit, or they could continue to do as they were doing and potentially lose money on every hospitalization. So we're shifting that financial risk to the hospitals. And really what this did is we saw hospitals become much more just churning people out. It was more admissions, shorter length of stays, great turnover, and the unintended consequence really was that graduate medical education started suffering, where instead of having adequate time to learn from your patients, you are now feeling like there's not enough time for anything. And really not all hospitals remained profitable. Once this happened, about 20% of the hospitals in the US in the 10 years following this closed. And primarily those were community hospitals. Some had residency programs, some did not. And so what about the funding of graduate medical education? So house officers initially were not paid, but they started receiving salaries in the 50s. And by the 70s, that cost was about 3 to 4% of the hospital's operating budget. Medicare, when it was enacted in 1965, kind of came in and saved hospitals with providing funding for resident salaries. But one of the reasons that residencies had, for much of the history, been inpatient experiences is because there wasn't a priority to, there wasn't, ambulatory experiences weren't seen as being as valuable. And so Medicare GME payments were only tied to hospitalized patients, not ambulatory patients. Initially, with the ever increasing costs of medical care, in 1997, the Balanced Budget Act established hospital-specific caps on these Medicare-funded resident positions and said, you can no longer, like, we're not growing this residency system any longer. At that time, the thought was that we were producing too many physicians, too many specialists to meet the needs of the country, and we would end up with a surplus. And so the government said, we're not going to keep funding this growth because I don't think we have the demand for it later. And since that time, there's really been very little increase in the growth of residency positions. So 99, they did allow a limited increase for rural hospitals. In 2010, the Affordable Care Act redistributed, so it didn't add positions, but redistributed some of the unused positions to try and get more people into primary care and rural programs. And then most recently in 2020, Congress did authorize 1,000 new Medicare supported positions to be started over the course of 5 years. So how does all this affect the learning environment and the people in it? And I do want to say my caveat. So this, I've got some comparison slides. It's not meant to be exhaustive. It is intended to be objective, not a good versus bad, or it was better back then. So let's start with our patients, our most important part of the learning environment. In the late 19th century, most are the charity ward patients versus private patients who could afford to pay for care. And so they were given care in the wards, which were large rooms. You can kind of see a little picture up at the top. Large rooms that had 16, maybe 24 or more beds in it. There was no privacy curtain. You were just one patient beside another. Medical care was seen as a charitable gift. Patients were seen as educational material, and it's one of the reasons why there were pretty high autopsy rates for much of the early part of residency, because regardless of the cause of death, there was always felt to be an educational benefit from doing an autopsy on a patient. And then you had that paternalistic model of patient care where doctors made the decisions, patients trusted their doctors. It there wasn't a lot of say. The patients didn't have a lot of say in what their care looked like. So compared to now, most patients had some kind of insurance or ability to pay. And medical care is seen as a right. We see patients often as consumers or customers of medical care. And we now have more of a shared decision-making model. We involve them in their care decisions. We no longer say, this is the best way. Here are all the options, and now you get to help decide. And what about the residents? So early on, we had the residents were white males. They graduated from U.S. medical schools. They were unmarried. Many programs actually required that you be unmarried. You had to live in the hospital. They were from a class that could afford to go without pay or with very little pay. They had a robust camaraderie. They were smaller programs, and their roles were learner and investigator. Their main source of anxiety came from, worrying about being cut from the program. And they were operating in a system or a culture where the belief was that bad outcomes were the result of their ineptitude or their individual error. There wasn't an idea yet about system factors. Compared to now, we have increasing numbers of females. Diversity is still something working on, always. But we also have increasing numbers of international medical graduates. We have residents who do not live in the hospital. They have more personal and familial responsibilities, whether that's a spouse, children, pets, home ownership. Now we have people coming into it, starting with about an average of $250,000 in educational debt. There's more feelings of isolation as larger programs become larger, more impersonal. The roles have shifted some to you're still a learner, but you're also a teacher and you're an employee. And one big source of anxiety is money. And that is really what led to moonlighting experiences. And this quote really spoke to me. This internal medicine resident who was at Mass Gen from 98 to 01 said, I came to residency expecting to work hard, to work as hard as I possibly could work, to get very little sleep, and to make very little money. What I did not expect was that I would work as hard as I could possibly work and still do a bad job for my patients and my own education. And I have felt, in addition to that, there are times that I feel like I am a bad mom. I am a bad spouse. I am a bad friend. And it adds a lot to try and still feel like I'm not doing a great job learning. And what am I teaching? I love the role of being a teacher as a resident. I think that's a great thing that we have taken on more role of teacher. But I thought about it, and I think everyone in the room should kind of think about, what do you teach when you're teaching someone, whether it's an attending teaching a resident teaching a medical student or intern, like what are you teaching them? Because I can tell you, when I thought about it, I am teaching them how to operate within our hospital system. I am teaching them not necessarily about medicine or the science. I am teaching them, how do you admit a patient? How do you order this test? Those are the things that I feel, how do I tell them, these are the admission criteria? This is what insurance will pay for. These are the things that I think about when I think back on like what I have taught, the bulk of what I have taught people in residency is I'm like, it's all about operating within the system. Yes, sometimes I am still able to like dive into a diagnosis or something really exciting. And that's where all of a sudden I remember why I went into medicine. And I find fulfillment in my job on the days where I am teaching them about a differential for a certain symptom and how to work it up, like really dive into why I think this is what's going on and the medical aspect, because that's fun, right? That is the fun part, not the, okay, this is why they got admitted and how do we get them out of here? So I just think about what you teach. And in that, faculty, there's a huge role of the faculty and the residents, and they have their own stressors and changes that have happened. So while we talked about like this deep commitment to teaching, at the time they were considered clinical investigators. That was their role. They were investigating. They were trying to move things forward. Now they're pulled in so many different directions. And so whether they are more on the academic side and they suffer from the publish or perish ethic, or they are more on the clinical side and it's all about RVUs and increasing clinical productivity, they've got those factors to deal with. And now they're seen more as practicing specialists. They're not investigators anymore. They are practicing specialists. They're required to do much more documentation, and they are dealing with a group of residents who, whether real or perceived, have a lack of curiosity and inquiry. One attending at WashU Med who had served for many years stopped in the 90s and he said house officers want to talk only about discharge and not about disease. And for him, it was no longer fun. He did not want to continue working on the wards. Department chairs. So early on, they were the heart and soul of residency programs. An intern was quoted as saying, "I felt his presence on a daily, if not an hourly basis." And they typically conducted our morning reports because they felt it was too important to delegate. They felt that educational opportunity was too important to delegate. It was the department chair who did the morning reports. And they were seen as personal chairs who oversaw and set the tone for the whole program. They formed relationships with their residents that lasted throughout their lifetimes. So now we had really a lot of their time consumed by fiscal and administrative issues of larger, more complex departments. And the running of a program is now on a program director. I'm sorry, I don't have a slide about program directors. And finally, everything kind of exists and develops within the cultural influences of that time. When residency first developed, there was really that two-tiered healthcare system. In America, the work ethic was very strong and it was promoted, and it was really work above everything else. And if you were going into medicine, you should expect to go into it with that being your highest priority and not anything, hobbies, friends, family, else. Ludmer does quote, like this is one of his quotes, "Marriage was viewed as women's work. The physician's spouse was expected to support her husband, raise the family, manage the household, and take charge of social affairs." And when there was a little bit of talk in there about, well, what happens if you have a woman who doesn't really agree with that? And I think it was William Osler who said, well, you need to marry the right woman. And last, there was little formal accountability of the medical profession. They were able to act and do and improve as they saw fit. to now, we have a lot more, our culture is a lot more shifting towards success, or a person's success or worth is more than one's work or career. And we have a lot more diversity in family life. There's not necessarily a two-parent household. There's not necessarily a person who works at home. It is a lot of, people working, everybody in the family's working. Maybe the kids are working too, okay? And we have more commercialization in corporate medicine and patient rights that do hold the profession accountable. So efforts to reform. What has been done? One topic is unionization. And this really isn't something new, but in 47, hospitals, because they were seen as charitable and nonprofit, they were exempt, and employees of hospital systems could not unionize. It was not allowed. But in 58, there was the Committee of Interns and Residents, which formed in New York City. And in 74, the National Labor Relations Act allowed employees of healthcare organizations to organize for collective bargaining. So pretty much right after that, the CIR went on strike to protest work schedules, which resolved when hospitals agreed to an 80-hour work week. We'll come back to the 80-hour work week. But in 76, right after that, the National Labor Relations Board said, well, interns, residents, and fellows are students. They are not employees. They cannot unionize. So from 76 to 99, when that was overturned, residents and that we were not able to unionize. But now we have about more than 40,000 trainees across more than 100 residency institutions are unionized. And why, when people have looked into it, why they're unionizing, it's commonly about working conditions, compensation, and representation within a system that they are feeling increasingly marginalized in. And so why unions and not our ACGME? And really, when you think about unions affecting more local change in your hospital and ACGME setting more minimum national standards for residency. And so with that, it really wasn't about the hours with Libby Zion. We talked about, I know Dr. Mueller talked about in 84 the death of Libby Zion, and that led to the Bell regulations. And I found it kind of entertaining when I read Dr. Bell's kind of account of how they came up with the 80-hour work week for those recommendations. And he was just sitting on the porch of his beach house that he had rented in Cape Cod with two of his physician friends, and they were reviewing the recommendations that the committee was going to make and thinking about what should the work hour limit be. He couldn't really come up with something. And so his friend said, well, there's 168 hours in a week. Reasonable to work a 10-hour day for 5 days a week, and it is humane for people to work every fourth night. And when he did the math, he said, all right, 50 hours plus 30 hours equals 80. And that's where it came from. But only one of the 17 recommendations in the Bell regulations concerned the work hour issue. And Dr. Bell expressed great frustration over time about why those regulations became so focused on work hours, because really it was supervision, not regulation of hours, that they felt was the key to improving the quality of patient care. But unfortunately, as we all know, it became all about the hours. The Institute of Medicine, when they released their To Err is Human, it really brought to light, or really increased that public concern for patient safety. And even though there wasn't much written about residents and residency within that report, it just brought it to the patient's mind. And so from public pressure, you had the introduction of legislation in the House and Senate to reduce work hours for residents. These did not pass because it was thought that it would be better addressed by the medical profession and not by the government. And so with that pressure, ACGME approved their new duty hour standards, which took effect in 2003. But the public, it's still, I mean, like the debate still raged on, and it eventually Congress asked in 2007, hey, Institute of Medicine, investigate resident work hours again, like let's look into this more. They came up in 2009 with resident duty hours, enhancing sleep supervision and safety. And in that, they really talked a lot about the learning environment, but it's still, the conversation remained about duty hours. And then ACGME revised their duty hour regulations, which took effect in 2011. Criticism of duty hours came mostly from within the medical community. There was a lack of evidence that increased hours and sleep deprivation is what was causing the mistakes and errors. One size does not fit all programs. There was a need for flexibility, not rigidity in how you are from, like, whether you're a general surgery resident or a pediatrics resident. That learning is very different. And so maybe your work hours should also have some flexibility in how you can work safely. And then really, it wasn't about the number of hours, but what is done in those hours. So we saw this compression of work and continuity of care, like continuity of care decline and compression of work. So trying to do the same amount of work, but in less time. And a cardiologist at UPenn who had a hospitalization experience said, it has become maddening and dangerously easy to pass the buck to the next shift worker, the next consultant, or to the outpatient caregiver. I had no sense that I was on a teaching service or part of an academic mission. I was a cog in a high throughput industry. And so really trying to turn the conversation into not hours, but learning environment, and how do we find adequate time to engage in reflective learning. Henry Christian, who was the first physician-in-chief at the Brigham Hospital, he said, the goal is to provide a varied but not too large a group of patients. Otherwise, a house officer will be so hurried in his work that he will not have time to do it well. And so there have been efforts to see how we can improve that. The integrated teaching unit at Faulkner Hospital, the study that these results come from is McMahon in 2010. And this integrated teaching unit was an experimental model designed to be educationally driven, where this rotation, you had 2 attendings, 2 upper-level residents, and 3 interns. And they capped their census, so the average census per intern for patients in the ITU was 3.5, and the average on the general medical service was 6.6. The hours that they worked per week were about the same, but their time spent in educational activities was increased on the ITU, as well as the time spent teaching. Time in direct patient care was about the same, and the average length of stay for patients was about the same. It didn't affect, patients needing to stay longer. And patient satisfaction was also about the same. But when you talk to residents and interns and ask them about the rotation, the majority of them enjoyed the rotation. They felt it was closer to an ideal training experience. They learned new physical exam skills. That's kind of my favorite one. We're learning more when we have time to go spend at the bedside with patients. And the attendings also liked the model and felt that they learned from their co-attending. Similarly, there's a leaky initiative at Johns Hopkins. This became a rotation required of all their Bayview internal medicine residents. It was similarly reduced patient load to give the residents more time to know their patients, to really get to know them on a personal level. And they also followed those patients even after discharge. They would make home visits. They published their curriculum for other residency programs to adapt for use in their own programs. So trying to disseminate, what they've created. The American Medical Association also had the Reimagining Residency Initiative. This was in, I believe, 2019 or 2020. They had a $20 million grant program to try and transform residency training. And there were 11 projects that were selected for funding. And some examples of it include one on promotion in place. So doing more of a time variable graduate medical education where instead of saying everybody has to be here for 3 years, maybe you have reached competency earlier, and instead of your last couple months being as a third-year resident, you are now operating under kind of like as an almost like a chief, where you're like attending, but you still have your safety net around you. Then there was this graduate medical training laboratory, and they actually put trackers on residents to see where they spend their time. And very little of that time is spent in patient rooms. If you want to know more about the various projects, you can go onto the website. They're interesting. But what are our barriers to change? Funding is still always a topic that comes up. Medicare is still the single largest sponsor of residency training. In 2009, the Institute of Medicine, in that report, they said estimated $1.7 billion would be needed to shift some of the current patient load, like to other staff, whether it would be PAs, NPs, other ancillary staff, to allow more time for reflective learning. Regulations. So we're still operating within, residencies have to stick to the regulations that ACGME sets. And then inertia. I think it's always easier to maintain that status quo. Change is hard. And so, but what can we all do? I feel like change begins at home. So whether you're advocating for change at your institution, on an institution level, and whether that's through the House Staff Association or whether you are part of a union, really trying to advocate for change at home, because there is not a one-size-fits-all for residencies. And then getting creative within your own program, figuring out what is possible to make what we already have more educational, more fulfilling, more enjoyable. I have a lot of ideas, but we're running out of time. So also, you can look for grant proposals with funding's an issue. So the ACGME actually has a Back to Bedside initiative. The most recent round of funding just closed, so unfortunately the next request for grant proposals will likely be in early 2028, but all you medical students out there, maybe that could be you, okay? Maybe you could be applying for grants to figure out how to cultivate joy and meaning in work and improving the physician-patient relationship, okay? And like, what are your ideas? What would y'all change? What would you do? Anybody like to share an idea or a thought?
I think, thinking about the tracker on residents. When I was an intern, we had Epic as an outpatient, but not inpatient, and they rolled over during my intern year. And I remember all of my interns, like we were all sitting in the room with my hemonc rotation, and my attending walked in and said, guys, the patients are out there. Mm-hmm. And it having all these changes in medicine and in technology have changed our ability to be at the bedside. So even AI, I mean, the more we start using AI, the less we are going to be at the bedside. And
Do you think that the more we use AI, the less we'll be at the bedside? Or do you think that there's a way to harness AI where it could get some of those?
There could be, but I think even with EMR, we are less at the bedside and people still aren't harnessing it in a way to be at the bedside more.
If we can unload some of the menial tasks from the EMR to the AI, I think that could help be at bedside, but we just have to be careful how we use it.
And identifying what those tasks are, right? Because are they menial tasks that are going to give you back a substantial, like, it has to, right, give you back enough time that that's going to make a difference. And yes, like a minute here, a minute there, it can all add up. But yeah, I think, figuring out what we do with AI.
It's how we use the technology we have, because I still remember that moment that we walked in and realized that change happened. We went from paper charts and being at the bedside to sitting at a computer.
Yep.
In a room.
And oftentimes I am, when I'm a senior on our ward service, I'm kind of looking at my clock and I'm thinking, hey, stop pre-rounding in the computer. You need to go see your patients. I would rather you not know everything that's in the computer and have actually talked to them and seen them, and it's okay if you don't.
Thinking about, like, we used to be at the bedside and could give a verbal order to get things done, but now you actually have to go back to the computer to get those orders in. You can't give those verbal orders like we used to. So that is also, it takes away from your time.
Yeah.
I will say for this DAX Copilot that they've rolled out, I'm so tired of hearing about wellness, and nobody actually, the only thing that has helped my wellness is the fact that I can spend time with my patients and not be on a computer. So when I'm in the room, DAX is recording and I am focused on my patient. And I think that has been huge, especially in outpatient where it's just constant turnover. There's no downtime unless they don't show up in droves. It's just one to the next and the next. But I think for me, I don't even carry a phone when I traditionally didn't carry a phone. I only want to see my patients. And I usually say, I can block everything else out. Just lock me in the room with the patients. Just move them in, one, out, in. I'm happy in that moment. It's the rest of the systems level error issues that aren't always managed at a systems level to make things efficient, that I think is a big part of what detracts us from why we all went into medicine.
Right.
Nobody went in. We all went in because we want to help people, want to do the right thing.
Yeah.
But so often that is not what we do in our
day-to-day,
hour
by hour. I can also remember feedback that I've gotten from throughout my time as a resident. I get a lot of feedback about efficiency. I will always forever be working on efficiency. But it always made me a little sad that was the only, I was like, I know I need to work on efficiency, but also what about the other things? What about how do you feel like I am establishing relationships with my patients? How do you feel like my clinical decision making? Am I doing the right thing for them? Am I testing too much? Am I not testing enough? Am I missing things? Am I not being thorough enough? But efficiency, it always bothered me that was kind of the primary thing. And even when I would have a supervised encounter and continuity clinic, and Dr. Drake's not here, but I'm going to just call him out anyway. He watched me in an encounter where I was just having a conversation with the patient. We don't have DAX, and I was going to write up all my stuff afterwards. And I don't always do it that way for efficiency's sake, but that time I did. And that was one of his big things. He's like, well, you know what? you probably should be just like writing your note while you're talking to them for efficiency, right? Like otherwise, and then I had a different supervised encounter with Dr. Swanson recently, where she was like, I really love that you were just like talking to the family and the patient and not like just typing on your computer. So, it's hard.
Well,
there are merits to both, right? There's merits to both, but.
Because even if you look at, I remember as a resident, like in our continuity clinics, they talked a lot about where the computer was positioned to be able to face the patient and talk. But, you also have people who are not as skilled at typing.
Right.
How can you continue that eye contact if you can't?
Correct.
Because Dr. Edwards had walked in once on me typing, and I looked up at him and I kept typing. He's like, how are you doing that? Like, because I had to learn how to do it. And so I'm just going to continue what I'm doing while you talk to me.
Okay. 2 hands at the back.
I think Dr. Herman had a comment. I think he had his hand up first, and he's online.
Okay.
Yeah. Can you hear me?
Yes.
Great. Dr. King, great talk. Thank you for all that. It's just a great description of the history of where we were and how we got here. I think when I think about it, healthcare is so complex, and it always has been. And if I'm thinking about residency education, I'm thinking about there are macro factors that we can try to affect on a really high level, whether it's legislation or ACGME or hospital system-based operations. Then there's the intermediate factors where we can probably make changes on a departmental level, and then there's micro factors that we can affect change either within the rotation of the class or even individual levels that we can change ourselves. I think your talks making me think about how we as a team need to look at always continuous, CQI, continuous quality improvement, of our program and ourselves, and put structure in place so that we can affect those intermediate and individual changes while advocating on those macro factors. So I know that sounds probably kind of esoteric, but I think that's the structure we need to put in place for our program. So thank you for that. It was a really, really good presentation to get the juices flowing.
Okay. All right.
Yeah. So good talk. Good points to contemplate. But for me, as a provider and a teacher, I want you to remember that residency is a finite period of time. It's good to kind of advocate, and I'm glad that we have the systems to advocate. But I'm trying to teach our residents how to think, how to be resilient, and how to get the answer. Too many times, I'm not saying as much, but you're like, this is what it is, what should I do? I'm teaching you to be that thinker. So efficiency is, I'm not very efficient, but efficiency is part of that. And we need to know, and because I think it's great about stressors and wellness and burnout, but you need to prepare yourself for the real world where you're taking a coin out and you're still in clinic and you're still, I would love to kind of, be in the room, but you're on call, you're getting calls from pediatricians, so you have to pick the right profession, but also, I hope I'm a very empathetic provider, but the purpose of training is not only the opportunities you get to be the physician that you want to become, right? But it's to learn how to, until all of these changes are made, to function and to, do I get it right all the time? But I want us to not just reflect on, gosh, why don't I get these opportunities, but what you're doing, balancing all the patients on the floor is a skill that's going to take you when you're in the real world and you have to juggle all those things. So that, I think, is just as important a learning skill and a learning goal as, how do we take care of an asthmatic? Because we do have the reason. I think open methodist is making me a little dumber because I'm like, ooh, it'll tell me. But it's the, I was always taught when I got fresh out of training, because I was like, oh my gosh, I'm not going to know the answer. You need to know, have the skills to get the answer. And so I think that's what residency trains us to do. And I think we can't lose sight of that. Otherwise, we get really upset about, why am I asked to do this? Why am I, this is just busy work. All of it is in preparation for what's going to happen in the real world. That's
It goes back to your comment about teaching the med students how to work within the system. We as attendings have to teach you how to work within the system.
Exactly. But I think my thought was more that, why? Why? Why do faculty, why is the medical profession, why have we gotten to this point?
Global healthcare issue.
Right. And so, but I think
We're on time.
we're at time.
Dr. Gagan had a.
Do we need to do the questions in order for it to be, okay, I put some questions in. I was just like, I don't want anybody to be like, oh my gosh, I was supposed to get some GM.
So Dr. Gagan, comment.
I just want to thank you for a wonderful talk, Rebecca. You did a great job. I was listening the whole time. And one thing I think that would be really valuable is to continue to tell the story of how we got here. I think that history is something that I didn't understand. When I graduated from medical school is when they handed me 80-hour work week, and my residents were like, oh, where do you get this? And I was like, I don't know. So I think to tell the story is an important piece of preparing our students and residents for the current reality. But also I think that helps spurs us to think of new solutions. I also am hopeful that in addition to the patient provider encounter, AI can help the learning experience. I signed up for an extra night when I was on my MS3 OB rotation because my first night, 0 babies were born. And I was like, man, no babies. And then on the other night that I picked up, 25 babies were born. And so having that idea that AI could help us keep track of what does your learner need, and why didn't my resident send me home at 1 o'clock in the morning? Well, it wasn't safe to go outside, but he also didn't let me go to bed. He was like, no, you're here for the night, 25 babies coming, let's go. So getting that sense of how can AI help protect our learning experience, keep track of the variety that we're trying to give them as students and as residents, because I think that's hard for us to necessarily write down in a notebook for every different topic. But all told, wonderful talk for us, lots of good things for us to think about, and can't wait to hear all your ideas.
I think that was my hope is I didn't want it to be about, I tried not to use the word wellness or burnout. I don't know if
Now
anybody.
you're killing me here. Your well-being. What's wrong with wellness?
But sometimes we focus too much. It's not that I don't want to talk about the concept of wellness. I just try not to use the terms. I think for me, inherent in a lot of the points is wellness. I talked about fulfillment, right? The fulfillment that I get from teaching someone or from having an interesting patient, and I'm like, oh my gosh, I'm going to dive into this and try and figure out like why this patient is doing what they're doing and doesn't make any sense. And then you get such fulfillment. To me, that's a piece of the wellness. But I tried really hard not to like make it all about the buzz of burnout and wellness and make it too much about criticizing and complaining. It's more of like, well, you know, how can we just think about all of these issues of how we got here and what can be done and what can I do? And I think that is important. Dr. Herman mentioned like at the individual level, you know, what can I do for my own sense of fulfillment? Is that like, I'm going to pick one patient a week that I see on the busy ward service, and I'm just going to like set that case aside and really like dive into it. Like set your own goals, right? What brings you satisfaction and fulfillment? How can you do that for yourself and not wait for other people to make it happen for you?
Thank you, Dr. King, for an excellent talk. Happy to take any other questions offline.